Blood flow stops, brain cells start dropping, you're on the clock. A stroke is when blood flow to the brain gets cut off, either from a clot or a bleed. Either way, neurons start dying fast. There are two main types of stroke. Ischemic, caused by a clot blocking blood flow to the brain. Hemorrhagic, caused by a ruptured blood vessel bleeding into the brain. Both are emergencies, but the cause, treatment, and outcome are very different. These two categories are further subdivided. Ischemic strokes have three main subtypes. Thrombotic, a plaque builds up in a brain artery, ruptures, and blocks flow. Embolic, a clot travels from elsewhere, often from the heart, thanks atrial fibrillation. Lacunar, damage to small, deep vessels from chronic hypertension or diabetes. Hemorrhagic strokes have two main subtypes. Intraparenchymal, a deep brain bleed, usually from uncontrolled high blood pressure. Subarachnoid, a ruptured aneurysm causing a thunderclap headache, neck stiffness, and this feels like death energy. Time is brain, act fast or neurons die. Red flag symptoms: be fast, one-sided weakness or numbness, slurred speech, vision changes or confusion, dizziness, balance problems, or that they look wasted but didn't drink vibe. Stroke is a clinical diagnosis. Do not wait for imaging to act. Let's talk core versus penumbra. Infarct core, dead brain tissue, no coming back. Penumbra, struggling cells that could survive if we restore blood flow fast. Goal, reperfuse and rescue the penumbra. Now let's talk stroke workup. 1. Non-contrast CT, rule out a bleed. 2. CTA, head, neck, check for large clot. 3. MRI, confirms early ischemia. 4. Labs, glucose, CBC, BMP, PT, INR, troponin, EKG. 5. NIH stroke scale, assess severity, guide treatment. Stroke treatment, why it's different. Ischemic strokes. Problem is a clot. Goal, bust it or pull it out. Hemorrhagic strokes. Problem is bleeding. Goal, stop the bleed and lower pressure. Treating the wrong one can kill. That's why CT comes first. Ischemic stroke treatment. Two main interventions: TPA, alteplase, or mechanical thrombectomy. 1. TPA, alteplase, Dr. Schweier's clot buster. Use within 4.5 hours of last known well. Do not give TPA if there's a high risk they might bleed or bust. That means recent GI bleeding, major surgery or trauma, blood pressure over 185/110, or an INR above 1.7. These are absolute contraindications to TPA. Remember, if they might bleed or bust, TPA is a bust. 2. Mechanical thrombectomy. If large clot on CTA, up to 24 hours from last known well, like a brain vacuum, sucks the clot out. Supportive care tips: giving TPA, keep BP 185/110 to prevent bleeding. Not giving TPA, allow permissive hypertension up to 220/120. Why? Higher pressure helps push blood into the penumbra, the barely alive brain tissue. Think of it like opening back roads to get around a highway clot. Aspirin. Wait 24 hours if TPA was given, otherwise, give immediately. DVT prevention, because stroke often makes you immobile, which is a clot risk. Hemorrhagic stroke treatment. You don't bust clots, you stop the bleed. Reverse any blood thinners. If the patient is on warfarin, give vitamin K and PCC, prothrombin complex concentrate. If they're on a DOAC like apixaban or rivaroxaban, give andexanet alpha, lower BP. Goal systolic 140. Call neurosurgery if hydrocephalus, herniation or aneurysm. Subarachnoid. Give nimodipine to prevent vasospasm, calcium channel blocker, keeps vessels open. Secondary stroke prevention. Why it matters. Once they survive, the mission is don't let it happen again. Strokes love to come back. Your job is to slam that door shut. Antiplatelets, stop artery clots. Statins, stabilize plaques. Anticoagulation, for cardioembolic strokes. AFib, control, BP, biggest modifiable risk. Lifestyle, no smoking, manage diabetes, eat something green. This isn't just recovery, it's long-term brain protection. Stroke, crushed it. Follow Boards to Bedside for more fast, dirty, high-yield breakdowns, from prep to chaos.